Thank you for the invitation to this wonderful symposium. It's always a great joy for my colleagues and me to come to this meeting and visit your beautiful country. Congratulations on Sejong for moving into the new hospital, the Mediplex, and for your successful transplant program. And thank you for putting me on staff. I have now I don't know if this means I'm going to be on call, but I'm going to have to learn Korean very quickly. So I'm going to talk about mTOR inhibitors, a class of immunosuppressive agents in cardiac transplantation. I have no financial relationships to disclose, but I will be talking about the off-label use of sirolimus and everolimus, neither of which are approved for use in cardiac transplantation in the United States. Everolimus is approved for heart transplantation use in 90 countries worldwide. This is a very special year in heart transplantation because in December it'll be the 50th anniversary of the first heart transplant, which was done in South Africa. Here is Christian Barnard, the first surgeon to do a heart transplant. And after that, the number of transplants increased dramatically. They dipped in the early 2000s, but are now increasing again to about 5,000 a year, about half of which are performed in the United States. And in the US, patients are getting older, they're getting sicker, they're more urgent transplants. The sicker you are, the more likely you are to get transplanted. More women and more patients maintained on mechanical circulatory devices, which we'll hear about later this afternoon. About 80% of our transplants are managed with mechanical circulatory support as bridges to transplant. And the major post-transplant complications are rejection and infection. Both of these we've been able to manage pretty successfully. Hypertension, nephrotoxicity are the complications of the immunosuppressive drugs, and with more judicious use of these drugs, we're better able to manage them as well. But the two limitations to long-term survival are cardiac allograft vasculopathy, or CAV, the transplant coronary disease, and malignancy. This shows the improvement in transplant survival over time from the early days to a more recent era. I think that's due to more effective use of immunosuppressive and more appropriate use of immunosuppressive agents, as well as better prophylaxis and prevention of infectious diseases. And if one looks at the causes of death after transplant, beyond the first year post-transplant, the major causes of death are cardiac allograft vasculopathy and malignancy. There also is nonspecific graft failure, which is due to cardiac allograft vasculopathy. And this again shows the causes of death: CAV, graft failure up here, and malignancy. If you add CAV and graft failure, that is the major cause of death. I'll skip that. So our immunosuppressive agents traditionally have been the calcineurin inhibitors, cyclosporin, tacrolimus, which inhibit T cell activation. The T cells mediate the alloimmune response to the transplanted organ. Mycophenolate and azathioprine, which are anti-proliferative, and corticosteroids, which inhibit a variety of different inflammatory factors. This is from a paper by Phil Halloran, a Canadian immunologist, from about 13 years ago. It's worth reading because it goes through immunosuppression. It's from the New England Journal of Medicine. And this shows where the mTOR inhibitors work. They inhibit a molecule called mechanistic target of rapamycin. mTOR is involved in proliferation of T cells and other cells, including smooth muscle cell proliferation. So inhibiting them inhibits T cell and smooth muscle cell proliferation. And here's where sirolimus works, inhibits target of rapamycin. Turns out the mTOR is also involved in malignancies, in proliferation of cancer cells, and is involved when it's activated in degenerative diseases like Alzheimer's disease. So there's some people who believe that mTOR inhibitors are good for whatever ails you, preventing Alzheimer's, cancer, etc. So this is the alloimmune response, which involves two signals. One is recognition of the foreign cell, and the other is a secondary signal. This is how the calcineurin inhibitors work. They inhibit transcription of IL-2, which activates the immune cells. We've seen this already. And acute rejection is when T cells recognize the surface, the endothelial surface of the transplanted organ, and antibodies are produced also. So you can have antibody-mediated rejection, cellular-mediated rejection, and without immunosuppression, they destroy the allografts. In the early transplant era, right after that happy picture I showed you of Christian Barnard doing the first transplant in South Africa, nobody knew anything about immunology, so most of those patients died very quickly of rejection or of infection from the massive doses of immunosuppression that was used to prevent rejection. But as a result of long-term damage to endothelium, you get smooth muscle cell proliferation, and that can lead to transplant cardiac allograft vasculopathy. This is the grading of cellular rejection. We grade it based on how many lymphocytes are invading the myocardium and how many myocytes have been destroyed. And these are the stages where we treat. There's myocyte necrosis here, and there's inflammation here. And these, if we got biopsies like this, we would treat these patients with steroids and increased immunosuppression. And if patients have rejection, their survival is reduced compared to patients without rejection. The fortunate thing is that we see rejection much less frequently than we used to. About 10 years ago, 50% of heart transplant patients would get acute cellular rejection. Nowadays, it's about 5%. So we're better at managing the acute problems after transplant, acute rejection and infection, but the long-term problems, CAV and malignancy, we're not so good at managing, and this is what kills most of our patients beyond the first year post-transplant. Let me just skip that. And I'll come back to this a little bit later, but it points to the fact that malignancy is very common in transplant recipients. And we've done a better job in terms of improving outcomes in patients, improving the freedom from malignancy by using less immunosuppression, but it still is a major cause of death. This shows the immunosuppression that is used most recently. So you can see tacrolimus has largely replaced cyclosporin, and a small percentage of patients are on sirolimus or everolimus. The major antiproliferative that's used is mycophenolate or Celcept, and azathioprine has largely disappeared. This also shows the continued use of the mTOR inhibitors. Tacrolimus remains the major immunosuppressive agent that we use, calcineurin inhibitor, and the major antiproliferative is Celcept. And these are the different regimens that are used. You see that the number of patients who receive mTOR inhibitors is still very low. This is cardiac allograft vasculopathy. This is from one of my patients who was transplanted. He received an 18-year-old heart. At the time, shortly after transplant, we did a coronary angiogram. The coronary arteries were normal. About a year post-transplant, he presented with heart failure and then developed sudden cardiac death. And this is LAD. This is the lumen. These are inflammatory cells, and this is smooth muscle cell proliferation. So he died of cardiac allograft vasculopathy, which caused heart failure and sudden cardiac death. And so ischemia, this starts actually even before the transplant procedure, when the heart is ex vivo being brought to the transplant center. The ischemia damages the endothelium, and there's immune and non-immune factors that cause further insult to the vascular endothelium, and that in turn results in an injury response, which in the vasculature is smooth muscle cell proliferation. And actually, probably closer to 50% of patients at 5 years post-transplant develop cardiac allograft vasculopathy. It can be diffuse and involve the entire coronary tree. We have a patient right now back in our hospital, an 84-year-old gentleman, a hematologist, who got his transplant about 20 years ago and now has cardiac allograft vasculopathy, also has renal insufficiency. His disease is too diffuse to do anything about in terms of interventions, and he's probably going to die of his cardiac allograft vasculopathy with nothing to offer. The histology resembles the intimal smooth muscle cell proliferation that's seen after in restenosis after angioplasty and stent deployment. And survival at 3 years after diagnosis is 60 to 80%, with severe disease, which is defined as a greater than 40% stenosis in 3 vessels, patients have a 6% 3-year survival. Death is usually sudden cardiac death, silent MI, or heart failure. Because these patients have denervated hearts, the ischemic events are silent, though there are patients who can present with chest pain. We have one patient who I think is known to some people in the audience who has cardiac allograft vasculopathy, and it presented with exertional chest pain, and then Dr. Ledley stented this patient. Dr. Ledley, take a bow. And the patient's chest pain went away. If you have cardiac allograft vasculopathy, this shows that we're doing better in terms of increasing the freedom from cardiac allograft vasculopathy, although it's still a major problem. And if you have it, survival is worse than if you don't have it. This is what it looks like angiographically. 3 years, this is 1 year post-transplant. 2 years later, obliteration of the distal and proximal vessels. And whenever you see a slide like this, it means we really don't know exactly what's causing the disease. So basically, we're including everything: ischemic time, reperfusion injury, hypertension, and hyperlipidemia may be mild causes, CMV, cytomegalovirus, an opportunistic infection that occurs in transplant patients may be part of the cause, and then perhaps some of the immunosuppression may be involved. But one thing that we see is we see elaboration of inflammatory response mediators and cytokines, and inflammation, smooth muscle cell proliferation. And we can see that by intravascular ultrasound. And this over here is intimal hyperplasia, which is an indicator, a marker of cardiac allograft vasculopathy and smooth muscle cell proliferation. And we use IVUS as a surrogate marker to help us do clinical trials and see if the clinical trials are affecting the disease. And this is intimal thickness, a result of smooth muscle cell proliferation from injury from cardiac allograft vasculopathy. This shows that angiography may not be very helpful. So this is the patient who had an angiogram. This area here looks normal. The patient died shortly after the angiogram, and here's an eccentric plaque missed on the angiogram. Another angiogram, this one here, patient also had IVUS here. I mean, this area looks normal. IVUS looks normal here. I'm sorry, no, here there's a lot of intimal thickness. This looks normal. Here there's relatively little, also looks normal. So probably the most sensitive technique is intravascular ultrasound. We don't use it in the US very often except as part of clinical trials because insurance doesn't pay for it. And we have a number of parameters that we use to determine severity of cardiac allograft vasculopathy based on IVUS, luminal area, intimal area. The most robust predictor is maximal intimal thickness, or the change in maximal intimal thickness from the baseline IVUS right after transplant to the IVUS a year later. And there have been a number of studies from Oxner in New Orleans, Stanford, and the Cleveland Clinic that showed if you had a change in maximal intimal thickness greater than 0.5 millimeters from baseline to 1 year, at 4 to 5 years, you're more likely to die, have myocardial infarction or heart failure. So it is a predictor of bad outcomes. And here's an example from the Cleveland Clinic of just such a change. This is the baseline IVUS, and this is the 1 year IVUS with change in maximal intimal thickness of 0.79 millimeters. Now, why am I talking about this? You'll see, because this is the major surrogate marker we use in studies of mTOR inhibitors. And the Cleveland Clinic group showed that if you have this change greater than 0.5 millimeters, all-cause mortality and death plus myocardial infarction were more likely to occur. Another study was a multi-center study looking at IVUSs in 125 patients. They divided them into those who had a change in maximal intimal thickness greater than 0.5 millimeters versus those who did not. And those who did were more likely to have death or graft loss at 5 years, more likely to have non-fatal major adverse cardiac events, and more likely to have significant new angiographic irregularities. So the greater the change in maximal intimal thickness, the greater the plaque burden and the greater the likelihood of adverse cardiac events. Now, why is it that we're seeing greater freedom from cardiac allograft vasculopathy? Well, about 20 years ago, there was a study published in the New England Journal of Medicine by Kobashigawa at UCLA at the time. He randomized patients to the statin pravastatin versus placebo, and showed that there was less CAV and better survival in patients who got pravastatin. A German group in 2003 repeated the same thing with simvastatin and showed similar benefits. So nowadays, every patient, regardless of whether they have hyperlipidemia or not post-transplant, is started on statins. There was interest in seeing whether mycophenolate compared to azathioprine could reduce likelihood of developing cardiac allograft vasculopathy, and in this clinical trial, there was less rejection with hemodynamic compromise, but by IVUS, there was no difference in terms of maximal intimal thickness or any of the other measures that we use by intravascular ultrasound. So there's no evidence that mycophenolate mofetil CellCept makes any difference in terms of cardiac allograft vasculopathy. And that's where the mTOR inhibitors came in, because it was thought, well, perhaps by inhibiting proliferation of smooth muscle cells, by inhibiting mTOR, you could reduce the development of cardiac allograft vasculopathy. And so the first study was done in Australia and New Zealand, one of the first studies by Ann Keogh, published in Circulation. They used sirolimus, 2 doses of sirolimus in randomized patients to azathioprine or sirolimus. Their primary endpoint was biopsy-proven rejection at 6 months, but they also used IVUS to look at the change in parameters from 6 weeks to 6 months. They found less rejection with sirolimus. They found increased serum creatinine, very interesting. And that's going to be something that we see repeatedly using these drugs. In terms of IVUS, there was greater progression of cardiac allograft vasculopathy determined by IVUS using azathioprine, but they did not see that using sirolimus. So sirolimus was able to reduce the rejection rate. Creatinines were higher, but it was able to slow the progression of cardiac allograft vasculopathy as determined by IVUS. And then the rest of the world did a study using everolimus, which used to be called RAD, and I had the honor of leading that study, published in the New England Journal in 2003. We used 2 doses of everolimus compared to azathioprine. This is our primary efficacy endpoint, which is composite of incidence of biopsy-proven rejection greater than 3A, moderate rejection, acute rejection associated with hemodynamic compromise, graft loss, death, or loss to follow-up. And the primary endpoint was significantly reduced in the 2 everolimus groups compared to azathioprine, and that was due entirely to reductions in the incidence of acute cellular rejection. There's greater freedom from acute cellular rejection with everolimus than azathioprine. And we had an IVUS sub-study to look at the effect on cardiac allograft vasculopathy. And what we found was there was less change in maximal intimal thickness in the 2 everolimus groups compared to azathioprine. And if you looked at other measures, intimal area, cross-sectional area, intimal volume, across the board, less progression of cardiac allograft vasculopathy with everolimus. And we determined the incidence of cardiac allograft vasculopathy by defining that as a change in maximal intimal thickness greater than 0.5 millimeters from baseline to 1 year IVUS, and found a lower incidence of cardiac allograft vasculopathy in the everolimus groups compared to the azathioprine group. Now you may say, well, why is it that you compared the drugs to azathioprine? The reason was at the time the study got started, which was in 1998, mycophenolate mofetil had not been approved for use in heart transplant patients in a lot of countries, including the UK. So the standard anti-proliferative drug that was used was azathioprine. But we figured it would be important to compare everolimus to mycophenolate mofetil. And the other thing that we learned from the first everolimus study was that if you use mTOR inhibitors with standard dose cyclosporin, you had increased creatinines, decreased GFR. There seemed to be some interaction between these drugs that caused renal insufficiency, and our Food and Drug Administration was not happy about that. So the next study, which I led, which is a worldwide study, compared everolimus with reduced dose cyclosporin to mycophenolate with standard cyclosporin in de novo heart transplant recipients. We also had an IVUS sub-study, and we had the same composite endpoint, and we also compared renal function. And these were the centers that were involved. So this was a 5-continent study. The only continents not involved were Africa and Antarctica. I'm not aware of any transplant programs in Antarctica, but we had U.S., South America, Europe. There was a center in Taiwan, and Australia and New Zealand were on board too. And this is the way the protocol worked. So 2 everolimus doses, and then the expectation was within 2 months you would rapidly decrease the target cyclosporin to achieve these low target cyclosporin levels. Mycophenolate would use the standard cyclosporin levels. Now you're probably also thinking, why did you use cyclosporin and not tacrolimus? At the time, the Food and Drug Administration mandated that all transplant trials be done with cyclosporin. That has subsequently changed, but back then we could not use tacrolimus. And so there was no difference in terms of the composite endpoint or the rejection rate between everolimus low dose and mycophenolate mofetil. And if you look at the various aspects of the composite endpoint, no difference there as well. There was increased mortality numerically in the high-dose everolimus group, and the Data Safety Monitoring Board had us stop the high-dose arm of the study. And it turns out the reason for that was that there was very high mortality in Germany. So there's something described as center effect, where a single high-enrolling center in a clinical trial with bad outcomes can affect the overall outcome of the study. And we had a country effect. We had a country that had very high mortality. We weren't aware of it at the time. But numerically, there was an increase in mortality in the low-dose everolimus group compared to the mycophenolate group. And it turns out this was due to infection. And if you look at who got infections, it was patients who got induction therapy, like thymoglobulin in particular, and that increased the risk of infection within the first year in patients who got everolimus compared to mycophenolate. So it actually makes sense. We know from other clinical trials and from clinical experience that excessive immunosuppression can lead to infection. We did a study using daclizumab, which is an anti-interleukin-2 receptor drug published in the New England Journal of Medicine, where we found that people who got thymoglobulin in that study were more likely to die from fungal infections. And there were other things that were risk factors for adverse outcomes. Use of left ventricular assist devices, because some of these patients were infected at the time of transplant, and patients with low GFR at the time at baseline. This also showed that there was a difference in renal function between the everolimus group and the MMF group, that even with the reduction in cyclosporin, target cyclosporin, renal function was worse in the everolimus group. So why was that? It goes back to something that I learned in 3rd grade, which is pay attention. People did not pay attention to the directions, and there were groups within the study that did not lower the cyclosporin levels, doses to the levels that were mandated. So if you look at people, centers that didn't do that, or centers that did do that, didn't do that, they had worse GFR in the everolimus group compared to the mycophenolate group, whereas centers that paid attention, the GFRs were the same. The other thing to note is that 2 years post-transplant, the overall mortality between the everolimus and MMF groups numerically were the same. The other big concern about using these drugs was the issue of wound healing because of their anti-proliferative effects. So after the first everolimus study came out, a number of transplant centers in the U.S., University of Minnesota, Newark, Beth Israel, and Stanford said, oh, we got to use sirolimus. That's the only drug we have available. And while they found, the Stanford group published their data and found better survival, they found a lot of problems with wound healing. So that led everybody to back off using these drugs early on. And so we looked at this as an endpoint. And what we found was no difference in medial stenitis, no difference in wound dehiscence, which was comforting. We did observe for the first time more pericardial effusions in the everolimus group, and more, while there was no difference in terms of tamponade, more patients who needed interventions like pericardiocentesis or windows. So another issue that can happen after using these drugs. So the next thing we did an IVUS study, as we did in the first study. We looked at change in maximal intimal thickness and other volumetric IVUS parameters from baseline to 1 year. And sure enough, change in maximal intimal thickness was significantly less in the everolimus group than in the MMF group. And the incidence of cardiac allograft vasculopathy was 12.5 compared to 26% in the MMF group. There was a study called CTOT-5, which was an NIH study, which looked at the incidence of cardiac allograft vasculopathy and a lot of biomarkers in heart transplant patients, and they found in patients not receiving everolimus but MMF that the incidence was 25%. So they basically reproduced what we saw. Very low rate of CAV and much less progression in terms of volumetric measures of cardiac allograft vasculopathy. So the summary is that there was a beneficial effect in terms of IVUS parameters. We do not know anything about clinical outcomes, though. We do know from the first everolimus study that there were less major adverse cardiac events in the everolimus population at 5 years than in the azathioprine population. We're collecting the data in this group to see if there is a difference at 5 years. But one of the problems was places did not reduce cyclosporin as they should. So when you use these drugs, you have to be very aggressive at reducing cyclosporin. From the first everolimus study, we found that whether your trough cyclosporin level was 50 or 400 at 2 weeks post-transplant and beyond, the rejection rate was the same as long as you had therapeutic everolimus levels. And these patients should be monitored echocardiographically, which they are anyway, to look for pericardial effusions. There were no difference in pleural effusions. Now, a number of other groups have figured out better ways of using these drugs with greater safety and with preserving the same efficacy. This is the scheduled trial from Scandinavia. So what they did was they started everolimus at week 7 to 11, and they completely weaned off cyclosporin. So these people at that point were off calcineurin inhibitors. They were just on everolimus, MMF, and corticosteroids, as opposed to another group that received standard therapy with cyclosporin. And they did IVUS. They found that the rejection rate was higher in the group that was on everolimus alone. And some of these patients had to have low-dose cyclosporin added. There was less cytomegalovirus in the everolimus group than in the cyclosporin group, which is something that's been observed in all the mTOR studies. And there was no increase in renal insufficiency. The GFRs were actually better in the everolimus group. And they looked at IVUS, measures of cardiac allograft vasculopathy, change in maximal intimal thickness, less progression in the everolimus group. You see that here. These are volumetric measures, and again, less progression using other measures in the everolimus group. And their incidence was higher, but there was lower incidence in the everolimus group than in the non-everolimus group. Let me just skip these. So, not using this de novo, but delaying the use and eliminating cyclosporin is a way to avoid the issues of pericardial effusions, renal insufficiency, and preserve the beneficial effects of this drug in mitigating cardiac allograft vasculopathy. And another approach is from Italy. This is the Everhart study. Luciano Pateno from Bologna led this. So what they did was they compared starting everolimus de novo with reduced cyclosporin versus a delay. And here's what they did. This is where they would wean off, this is where they would switch mycophenolate to everolimus. And here's where they use everolimus in the very beginning. And this is the therapeutic range of everolimus. They would reduce cyclosporin levels in the everolimus group significantly. And the Italians were very rigorous at doing this and were successful. And so what did they find? They looked at GFR, they looked at rejection rates. They did not look at IVUS. Let me just skip that. They looked at wound healing. That's their enrollment, demographics. And what they found was that from the composite endpoint, which was evidence of pericardial effusion and wound healing, that the delayed group had less of those issues than the group that got it immediately. Again, pointing out, and here's pericardial effusion, and wound healing, pointing out that delaying the initiation of everolimus may be a better way of avoiding these cardiac events. Now, they have not reported their IVUS data. They are doing IVUS data, and but we'll have to see whether there's a beneficial effect on the effect of cardiac allograft vasculopathy. So introducing everolimus 1 to 3 months post-heart transplant is feasible in over 95% of patients. Does not increase the risk of developing more rejections, and results in less adverse events. So this is the other alternative way of using these drugs. And another group that starts the mTOR inhibitors late is the group in Mayo Clinic at Rochester. They've switched patients. This is not a randomized study, but they switched some patients to sirolimus and withdrew cyclosporin completely, about on average 1.2 years later. And they did IVUS in that group compared to controls, and found less progression in the sirolimus groups compared to the calcineurin inhibitor groups. Less progression. This is the sirolimus group. These are the cyclosporin groups. And actually, they showed better survival in the sirolimus group compared to the cyclosporin group. One thing they did find was if you make the switch beyond 2 years, there's no beneficial effect. Now, the other question that comes up is, what do you do about all these people who have established cardiac allograft vasculopathy? Well, there's actually not a lot of data about this, but there may be 2 studies that looked at this. This is from Donna Mancini at Columbia, close friend of Suk Jin's. What she did way back when was she took a group of patients with established cardiac allograft vasculopathy and added sirolimus to their immunosuppressive regimen, and they found that there was less progression of catheterization scores. And if one looked at a composite of catheterization scores, need for PCI, or bypass surgery, or acute MI, there was less in the sirolimus than the control group. Another study is from Spain, the Everostat group, where they randomized people with established cardiac allograft vasculopathy, defined angiographically and verified by IVUS, to either get everolimus with decreased cyclosporin or to continue on cyclosporin. Their numbers were very small. And so they looked at major adverse cardiac events. They too were successful in reducing cyclosporin levels. So as opposed to the big clinical trial that I led, these guys were able to really reduce cyclosporin. They did not find issues with renal insufficiency, but they found no issues in terms of major adverse cardiac events. And I think part of that's due to just having a 2-year follow-up and having small numbers. They did do an IVUS sub-study, and what they found was less progression in the everolimus group than in the standard immunosuppression group. This is everolimus versus standard for maximal intimal thickness and volumetric measures. The other issue is whether these drugs can be beneficial in patients with malignancies, because remember I mentioned mTOR is involved in proliferation of cancer cells, and malignancy is the other big cause of death in these patients. So this is a registry from the United States, what's called the SRTR, and what they looked at was they looked at patients, PSI is another term for mTOR inhibitor, it's proliferation signal inhibitor. Patients on mTOR inhibitors alone or mTOR inhibitors plus calcineurin inhibitors had significantly lower rates of malignancies than patients receiving calcineurin inhibitors. And that's shown here. And we are seeing greater freedom from malignancy because we use less immunosuppression. But if you develop malignancy, your outcomes are worse. And there's a lot we don't know about how to evaluate malignancies in these patients, which immunosuppressive agents to use, the duration and intensity of immunosuppression, the relationship to cancer risk, whether using low or minimal immunosuppression is beneficial, and how frequently should we do cancer screening? Should we do the American Cancer Society screening approach, or have different components of cancer screening, for example, like CAT scans of the lungs in patients who were smokers pre-transplant? But this shows mTOR involved in smooth muscle cells and also involved in malignant cells. So it turns out mTOR inhibitors are also used as adjuncts in oncology. And this is an everolimus study, Bolero 2, which is used in patients, women with metastatic breast cancer. It was a randomized study of everolimus plus aromatase inhibitors versus aromatase inhibitors, endocrine therapy. And what it showed was less recurrence in the everolimus group. And so everolimus has actually been approved in much higher doses. This is 10 milligrams a day compared to 1.5 milligrams a day we'd use in heart transplant patients. Has been approved in breast cancer and renal cell carcinoma in the United States. This is a study published in the New England Journal of Medicine, kidney transplant recipients with CAPACIS sarcoma on cyclosporin and MMF, both of which were stopped. They were started on sirolimus, and the CAPACIS disappeared. At least that's what they say. I'm not a dermatologist, but so it turns out in this specialized disease that is actually virally mediated, starting mTOR inhibitors may be beneficial. So just to summarize, use of mTOR inhibitors, also otherwise known as proliferation signal inhibitors, reduces the rate of CMV infections, reduces the incidence and severity of cardiac allograft vasculopathy, allows significant reduction of CNI doses and target trough levels, may reduce the incidence of malignancy, we don't know, may adversely affect wound healing, especially sirolimus, potentiates the nephrotoxicity of CNIs. In some of the studies, there's an increased rate of bacterial infections, though there's not an increased death, does increase triglycerides, and if you use concomitant thymoglobulin therapy, that increases death from infection. And the other thing, if you're going to start it de novo, obtain echocardiograms to determine whether there's significant pericardial effusions, and be careful using these drugs in people with underlying renal disease, infected VADs, and there may now be strategies both defined from Scandinavia and from Italy of starting these drugs later and avoiding the issues of wound healing, pericardial effusions, and renal insufficiency. Thank you very much for the invitation, and thank you for your attention.